First, we're going to be talking about the new frontier with FDA approvals in small cell lung cancer. And to be honest, I can't think of a better person than my friend, Dr. Eric Singhi, to start this conversation. Dr. Singhi is a thoracic medical oncologist at University of Texas MD Anderson Cancer Center, where he focuses on patient education and research in lung cancer, including young onset disease. He's deeply involved in training the next generation of thoracic oncologists and truly improving quality and safety in patient care. You will not see someone better about educating and empowering than Dr. Eric Singhi. And what I really love is that he shows up for our community time and time again, not just in the clinic and research, but in the everyday moments, awareness, advocacy, and making sure no one is alone. Some of you may know him as the Lung Onc Doc on TikTok and social media, where he's bringing up education and in ways that are engaging, applicable to real life, approachable, and involving just a little bit of dancing. So if we're lucky, maybe he'll do a little dance for us today. That kind of energy, that willingness to meet people where they are is exactly what this space needs. So please join me in welcoming Dr. Eric Singhi to the podium.
Welcome to Texas. It's really sunny and beautiful, and today it's just gloomy and not so great, but hopefully it'll get better this weekend. Want to say thank you to Dr. Shields, Longevity, the Small Cell Smashers. You'll notice I'm wearing a t-shirt that means the world to me. A patient and her care partner actually made this for me. It says, defeating small cell lung cancer one smash at a time. And I think that's the power of community. So I actually referred this patient, the care partner, to the Small Cell Smashers, and it's been transformational in terms of the support, the hope, the education that happens, and that's the reason why we're here today. So with that, I have the easy job of setting the stage for all the speakers to come. And by easy, I mean talking about what's happened in small cell lung cancer over the last 5 to 6 years. So what do patients and their care partners need to know? These are my disclosures. There's a little bit of lag with this, so just hang with me. We're losing sound again, I think. Okay, all right. Struggling a little bit. Oh, okay, got it. All right, I'm back in the podium. Can you guys still? It's cutting out. Hello? Nope. Can you guys hear me now? Okay, all right, we're gonna try again. I promise we're gonna get through this. Okay, so in the lung cancer space, what has it been like? So this is small cell lung cancer, waiting to be center stage, right? This is what it's been like for years. But honestly, the time is now. Dr. Shields, others in the field are making strides for patients. And not only behind the podium like I am right now, but also on social media. I think it's really important to share all these advancements that are happening in real time with patients and their care partners. So before I get into that, I want to talk a little bit, set the stage for small cell lung cancer. Many of you know this already, but I just want to make sure everyone's on the same page. Small cell lung cancer is a fast-growing type of lung cancer. It's the minority of lung cancer cases, about 13 to 15%, but still very meaningful. And often it responds well to the treatments that patients have up front, first. But really what the problem is that it can come back quickly and it can come back with a vengeance. But after 30 plus years, right? This is really the time where we're starting to have recent approvals. I'm going to show you what's happened over the last 5, 6 years. So let's go. We're ready to hear about this. So before we get into that, how does small cell lung cancer present? Like I mentioned, it often grows quickly, and so symptoms are developing over weeks to a few months. Lung-related symptoms can include things like cough or shortness of breath, and that tumor can move outside of the lung to areas that are nearby and can cause changes in voice like hoarseness. You can even see swelling of the face or neck. And then if it moves outside of the chest, outside of areas near the chest to other parts of the body, depending on where it's located, you can have other symptoms like headaches if it's involving the brain, bone pain if it's going to the bones, and then even just generalized symptoms like fatigue, losing weight when you're not trying, loss of appetite. And there's also some rare side effects or effects that happen. They're called hormone-related symptoms known as paraneoplastic syndromes. So that's the what. The next question is, where is the disease located? And this is really important. This is what we call staging of small cell lung cancer. You can have limited stage, and that's the abbreviation, SCLC. It's where the cancer is in one area of the chest, and what we're doing is we're aiming to treat it aggressively. We're trying to aim for cure when we treat. This happens in about 4 out of 10 patients where they're coming to us with limited stage disease. It's confined to one area of the chest. And then there's extensive stage small cell lung cancer, SCLC. This is where the cancer is spread beyond the chest, and it can include other areas, like I mentioned, the brain, the bones, even can include fluid around the lungs, around the heart. We count that as extensive stage small cell lung cancer. This happens in about 6 out of 10 patients that we meet for the first time with a diagnosis of small cell lung cancer. And our treatment for these patients is focused on controlling the cancer, helping people live longer, and hopefully helping them live well, which we're going to talk about. So how do we figure out where is the small cell lung cancer located? Right now, we do that with imaging. So an MRI of the brain to take a really good look at the brain, and then whole body scans, including a PET scan or a CT scan and a bone scan. Those are different ways to look at where the disease may be located. What's really interesting is that PET scans are really a good modality of imaging to figure out first where the cancer is located. So you can see here, almost 19% of patients, once they get a PET scan, they actually get upstaged. What that means is that more cancer is found than was expected initially. And then interestingly, 8% of patients can be downstaged with a PET scan where they say, hey, listen, actually, we found less cancer than we thought there was going to be. So that can really make a difference. So what did our treatments used to look like for patients with small cell lung cancer before 5, 6 years ago? So for limited stage disease, we use chemotherapy and radiation. For extensive stage disease, we use chemotherapy plus immunotherapy. Immunotherapy was approved in 2019, so that wasn't very long ago for patients in this space, but still longer than 4 or 5 years ago. And then if the cancer came back, that's where we really ran into trouble. There were limited options, and it was mostly chemotherapy. So what does it look like in 2026 and beyond? I'm going to set you up for what the recent FDA approvals have been, and then Dr. Gay is going to take it from there and tell us what the beyond factor is. But this is a really nice illustration that I adopted from Dr. Shields that published this, just showing you the different types of drugs that are involved now for patients with small cell lung cancer. So let's review this together. So let's start with chemotherapy. You guys know this. This is a traditional treatment that targets fast-growing cells. Those fast-growing cells include cancer cells, right? These are some examples of drugs: carboplatin, cisplatin, etoposide, lurbinectidine. Then we have monoclonal antibodies, which we call immunotherapy in this space. And what they do is they basically take the brakes off of your immune system so that they can go after those cancer cells. They really rev up the soldiers of your immune system, the T cells, to recognize and go after the cancer cells. So the drugs that we have looks like, sorry, the formatting is a little bit off on the slides, I apologize, but atezolizumab and durvalumab. And then we have something called a bispecific T cell engager, or BiTE. This is a relatively recent approval that happened that we'll talk through, but basically the drug is physically connecting the immune cells to the cancer cells so that they can go after them and destroy them. And the drug that we have is tarlatamab. And then we have something called antibody-drug conjugates, or ADCs. I usually call this sexy chemotherapy or targeted chemotherapy. Here I'm going to tell you that it's guided missiles that carry chemotherapy directly to the cancer cells. What I'll say about this is that these are not yet approved. They're accessed on clinical trials, so I'm not going to talk about it today. Dr. Gay probably will. But what they're doing in that purple box there is they're going after proteins that are very highly expressed on small cell lung cancer cells and allowing these guided missiles to go directly to the small cell lung cancer cells and drop a really high dose of chemotherapy directly into it. So we're going to talk about all this together, but essentially this is progress, right? So this is just a timeline of what's happened in the last 5 years, both updates in extensive stage small cell lung cancer and limited stage small cell lung cancer. We're going to go through these together. So let's start with limited stage small cell lung cancer. Remember, guys, this is the disease that's confined to one area of the chest. So we recently had an approval for durvalumab in limited stage small cell lung cancer, and it was approved after patients got their chemo and their radiation. So now some patients can receive that drug, durvalumab, which is an immunotherapy drug, for up to 2 years. And it's given if the cancer has not grown after patients received chemo and radiation. This approval just happened in December of 2024. This approval is based on data from the Adriatic study. And essentially what this study was asking was a phase 3 study was, will the addition of immunotherapy after a patient finishes chemoradiation therapy for limited stage small cell lung cancer, is it going to improve outcomes for our patients? And so we'll walk through this together. This was presented at ASCO in 2024. So these are curves that we are obsessed with as oncologists. If you go on Twitter, if you go on the Facebook groups, you may see many of us oncologists sharing these curves. These are called overall survival curves, overall survival OS. And this is really the curve that everyone was waiting for at ASCO 2024 to figure out, okay, what are we going to see, what are we going to do? And what you can see here is, I'm going to kind of walk you through this because this is kind of confusing. Let's make this easier to understand for people. So let's cross that out. We're going to say patients lived longer with durvalumab. The blue line is durvalumab, that's the immunotherapy. The orange line is no immunotherapy. And then the y-axis is showing you the percent of patients that are still alive based on different time points. What you can see here is that more patients were alive at 2 years, so 68% of patients were still alive if they received immunotherapy at that 2-year mark versus 58% of patients. That's what we're looking at. That's what this curve is showing us. And if we zoom in even more, what this is overall translating to is almost a 2-year improvement in overall survival, how long patients live if they got durvalumab or immunotherapy. And that's why this became practice changing. That's why we got the FDA approval. Now, just as important as understanding that this drug works is how well was it tolerated, right? How safe was it? What you can take away from this table is that for patients on the immunotherapy, only 1 out of 3 patients were able to complete the full 2 years. The next question is why? Why couldn't they get through the 2 years? About half the patients had to stop because unfortunately the cancer had grown while they were on the immunotherapy. And about 16% of patients had to stop because of different side effects. One of the side effects that we worry about is something called pneumonitis or radiation pneumonitis. This is basically lung inflammation that can happen. And this is a real risk for patients that have just gone through radiation, that have just gone through and started their immunotherapy. So how often does it happen? So about in 38% of cases, patients will have any type of inflammation. Thankfully, low amount of more serious inflammation, about 3%. And usually we can manage it by helping the patient using different modalities like steroids and talking to a pulmonary lung doctor to help us get through it and with close monitoring. So what are the takeaways from this Adriatic study? Immunotherapy in limited stage small cell lung cancer is helping patients stay in remission longer. It can improve the chances of living longer. It does not replace chemo and radiation for patients in the limited stage setting. And how I think about it is it's an extra step after treatment. And what I tell patients is this is like a reinforcement therapy. After you've completed your chemo and radiation, we're going to start you in immunotherapy, and this is really trying to reinforce the time that hopefully you can stay in remission longer. There are those side effects to watch for, which I pointed out. So the lung inflammation, the pneumonitis. Remember, guys, that's a really important one in lung cancer, and then fatigue. So that's limited stage. We're going to hop over to extensive stage small cell lung cancer. Again, this is where the disease has unfortunately moved outside of that one area of the chest. So what's happened in the last 5 years? Before we get into that, I told you in 2019 was when we got the approval for the first time to be able to add immunotherapy to chemotherapy for patients and see if there was a difference. And so one of the questions that we're always asking is, does that difference translate into long-term improvements, long-term outcomes for our patients? What's happening 5 years after patients start drugs like immunotherapy and chemotherapy? So that's what this graph is showing you here. What we can see now is that about 1 in 8 patients, 12%, are still with us at the 5-year mark if they were started on chemotherapy and immunotherapy. And the graphs I've circled in red there, what we're looking for is that tail of the curve. We always talk about that tail of the curve, and that's what I circled in red, and that shows us a potential for long-term survivors. And that's about 12% of patients, even with stage 4 disease that's moved outside of the chest. If they start chemoimmunotherapy, they're still with us. 12% is not enough, and I absolutely agree with that, but it's progress, and we're going to keep building on it. In addition to improvements that we've had, we've also thought a lot about how can we help patients support patients through all the different treatments that they're getting. Remember that treatments can cause a lot of different side effects. They can start to take a toll on your body. And so this was an approval for trilaciclib, which was approved in 2021 to help reduce myelosuppression in small cell lung cancer. What does that mean? Well, what it is it's a drug that's given before chemotherapy, and it's trying to help protect your blood cells. And what we've seen through trials and how it got approved was fewer complications and less extra support that's needed, so less blood transfusions, for example. So we've talked a little bit about immunotherapy coming into extensive stage small cell lung cancer, talked a little bit about a drug that got approved to help support patients as they make their way through their journey with treatment. Let's talk now about what else can we do after patients get chemotherapy and immunotherapy. How can we try to keep those patients and their disease under control for longer? And that was data that we just heard about too from ASCO, our biggest cancer conference that happens in Chicago, from the phase 3 IMforte trial. This is looking at lurbinectedin plus atezolizumab. What it's asking is, can lurbinectedin, a chemotherapy drug, plus atezolizumab, an immunotherapy drug, can it help cancer stay under control after patients get that initial treatment for their extensive stage disease? So this is a really complicated study design. I'm going to try and break it down a little bit easier to understand. So in the yellow box on the left side, basically patients that were enrolled in the study were newly diagnosed with extensive stage small cell lung cancer. They were relatively well patients, fit, healthy overall. And then they received their standard treatment with chemotherapy and immunotherapy. After they received their initial treatment, the question was asked, what's better? And so should we do immunotherapy alone? Or should we add another chemotherapy drug like lurbinectedin to the immunotherapy? And what they were looking at was, one, how long patients live, and second, how long is the cancer stay controlled? And what we saw, first to address the question of how long is the cancer controlled, was that adding that chemotherapy drug, lurbinectedin, helped patients stay under control longer. They had about a 46% lower risk of the cancer growing or worsening. That's what those curves are showing you there. The biggest takeaways from these curves when you look at them, we're always trying to figure out, do they separate? Do they separate, and do they separate early? Because that means that patients are deriving a benefit sooner rather than later, and they're deriving a real benefit as those curves separate. And the red circle there is showing you that more patients are particularly controlled at that 6-month mark. So trying to help you guys understand these curves, because it took a lot of time. I work with a lot of our trainees at my institution too, and it's complicated. We are not statistics pros, but we have to figure out how to take this information into our clinic and explain it to our patients, right? So what about how long patients live? What they saw, those OS curve, it's back again here, is that patients lived longer when chemotherapy lurbinectedin was added to the immunotherapy. There was a 27% lower risk of death. And again, that's showing you there that on the blue curve for patients that got the chemo and the immunotherapy, there were more patients alive as compared to patients who received immunotherapy alone. So why does this matter? Well, this was a new successful approach that helped patients after their initial treatment. Patients lived longer, and it helped keep the cancer stay under control longer. So Dr. Balazs Halmos is a fun colleague of ours who has probably got the best meme game in all of lung cancer and oncology, honestly. And so the drug is lurbinectedin, and so he said, guess we will use more lurbication in extensive stage small cell lung cancer management from here on, right? And that's the reason why, because of those curves that I showed you and the meaningful outcomes for patients. I think there are some things to keep in mind here, though. We did see more side effects for patients that got the 2-drug approach, right? When you add in chemotherapy to the immunotherapy, you're gonna see more side effects, A plus B, probably more side effects. And we took away that chemotherapy break for patients, right? So usually patients would get their chemotherapy and their immunotherapy. The chemotherapy was a very time-limited course, maybe 4 to 6 rounds, and then you just went to immunotherapy. Now patients may still have to be on the chemo, right? Because we saw that benefit in helping them live longer, helping keep the cancer under control longer. So we've talked about extensive stage that's newly diagnosed. Now we're gonna move to what happens if the cancer comes back, right? After a patient's been treated with chemotherapy and immunotherapy. We call that relapsed extensive stage small cell lung cancer. And unfortunately, despite the chemotherapy and the immunotherapy, the majority of our patients will have that cancer come back, start to grow. Historically, there's been very limited options, and we've always defaulted back to chemotherapy, but we're always trying to do better because the outcomes were not great. So now we have a new approval for a drug called tarlatamab, and this is a drug that's used after patients get platinum chemotherapy, and what it's doing is it's helping the immune system find, recognize, and attack the small cell lung cancer. So here's Dr. Shields. She said it the best way in a metaphor that it has continued to, no pun intended, stick with me for quite some time. And she said, I want you to think of tarlatamab like super glue. And what it's doing is it's gluing the cancer cell and your T cell, your immune soldier cells, together. So let's walk through that. So there it is, there's tarlatamab, that's the drug, and it's this super glue that's directly connecting the cancer cell, your small cell lung cancer cells, to the T cells. And it's doing it through a protein called DLL3, that's on your cancer cells, and CD3, which is on your T cells. And as a result of them being directly glued together, you can get this destruction of the cancer cell, and that's what we want, right? We want to blast up those cells, we want to destroy those cells. And this is what led to FDA approval of this drug for the first time in May of 2024. How did we get this information? So these are some more really interesting curves. These are probably my favorite, I don't know, Misty, these are probably my favorite graphs to look at, to be honest, because what they are, let me explain them to you. Each bar that we're looking at is one patient, right? This is why patients are so important. We even see them in our graphs. Every single one of those bars is a patient and their experience. What you want to look for is that the majority of bars are going downward, because what that means is many patients had tumor shrinkage. So if it goes down, that's actually a good thing. That means shrinkage of the disease. If it goes up, that means that unfortunately the tumor is growing. But you can see the majority of those bars on that left-hand side of the graph are going down, which is exactly what we want. What this translates into is about 4 out of 10 patients had their tumor shrink with the 10 milligram dosing of this drug, tarlatamab. So really exciting to see this information and data, but of course we gotta go back to the safety. Is this a safe drug to be giving our patients, making sure that our care partners are also armed about the information that may happen if patients are on these drugs, right? One of the unique side effects with this drug that you may have heard about is called cytokine release syndrome, CRS. If you think about it, we're super gluing your immune system cells to the cancer cells. And so you want to get your immune system activated. You want to get it supercharged. But sometimes it can get a little too supercharged. And that can cause different types of symptoms that are related to the inflammation. So this is what cytokine release syndrome means. It's happening in almost upwards of 50% of patients. About half of patients will have some degree of it on this drug. But thankfully, it happens early, often during that first treatment. Most cases, thankfully, are mild. And you can treat it usually if it happens with supportive things like giving the patient fluids, giving some other medications to help calm it down, and rarely has it required stopping the drug entirely. Another unique aspect about tarlatamab is the dosing schedule. So guys, normally you can go to your infusion clinic, you can see Dr. Shields in clinic, and then go to the infusion center and get your treatment, then you go home. With this drug, to start off, as of right now for most places, it has to be very carefully given and has to be given what we call step-up dosing, where you get a baby dose on day 1, and if things go well, you start to escalate the dose to make sure it's safe. The other unique aspect of this is you have to be in the hospital at most places as of now for that day 1 dose and that day 8 dose. So it does take a lot of logistics and planning to be able to safely get this. So how did we get the approval for tarlatamab? Again, we're back to ASCO. I'm actually really mad because I don't think this, we didn't get a plenary that year, right, for lung cancer, but we had so many interesting data that came out, right? So, I think lung cancer should always take the center stage, but I guess we got to share the stage with other types of cancers too. It's fine. But this is data from the phase 3 Delphi 304 study. And what this study was looking at was, is this new treatment tarlatamab that I just talked to you about, is it better than resorting back to just traditional chemotherapy if the cancer comes back for a patient? So this is, again, a study design. I'm going to make it a little bit easier for you guys here. Okay, all right. So first on the top left there, patients whose cancer came back after initial treatment. That's who we were looking at. Then if it came back, patients were randomized to either get chemotherapy or the tarlatamab, and that's really that second-line treatment, their second treatment that they get. And what this study was looking at was, do patients live longer based on which treatment they get? But it also looked at how long the cancer stays controlled and the side effects that come up. So this is really the overall survival curve. I told you, I promised you I was going to keep coming back during this presentation. What you can see is that this translates to patients who receive tarlatamab, they had a 40% lower risk of death than if they received chemotherapy. Not only that, what I really care about, what we all care about, is our patients feeling better if they get a particular treatment one over the other. And what they saw was that patients reported feeling better, especially with breathing and especially with their cough, if they got tarlatamab as compared to a chemotherapy drug. So you can see on the left side there, the breathing improved with tarlatamab. It actually worsened with chemotherapy. And then in the middle graph there, you can see that more patients improved their cough if they were on tarlatamab as compared to chemotherapy, so 16% versus 9%. What about the tolerance? How well was it tolerated? Was it safe to give? What they actually showed in this study was that tarlatamab, compared to chemotherapy, had fewer severe side effects. There was less of a need to stop or reduce the treatment dosing. And most patients were thankfully able to stay on the treatment and complete the treatment. So what does this all mean, right? Well, here's Captain Obvious. Patients are living longer. They're feeling better. And so this is really where this became practice changing, where we said, hey, if a patient has gone through chemotherapy and immunotherapy, unfortunately their disease comes back, our preference for most patients outside of a clinical trial is tarlatamab, right? Because patients lived longer, they felt better, their breathing was better, their cough was better, and they had fewer side effects than chemotherapy. At the same time, there is some caution with this study, right? Remember that this is going to require close monitoring. You have to be in the hospital to get the drug for the first 2 doses. There's some really unique side effects that not everyone is comfortable with, that cytokine release syndrome, some of the neurological symptoms that can happen too. And unfortunately, it's not readily accessible everywhere, right? And so I think that's an important thing to emphasize. So I'm almost done here. I think here are my big picture takeaways. As you can appreciate, just in 5 going on 6 years, there has been absolute real progress in small cell lung cancer. So if I was up here, I don't know, Misty, if you made this group 6, 7 years ago, that would have been me on the left side. That's all I have to say about that. We're done. Mic drop, right? But today, you can appreciate that as of 2026, we've had multiple approvals, and Dr. Gay is going to walk us through the beyond, that there is absolutely progress. There are new treatments that are being developed, and it's really going to depend on your stage of disease, the timing of your cancer journey, and any prior treatments that you had received. And then we are moving towards a more personalized and more effective treatment paradigm for patients with small cell lung cancer. There's a lot of FOMO right now for patients that have small cell lung cancer versus non-small cell lung cancer. I get to personalize my treatments all the time for my patients with non-small cell lung cancer, But don't lose hope. There's absolutely coming, I think, in this time, in this space, to personalized treatments for patients with small cell lung cancer. I think questions to ask your team: what stage is my cancer? Am I a candidate for newer treatments? What happens if my cancer comes back? And please keep asking about clinical trials. Are clinical trials an option? So make sure you take this back to your team, next week, whenever you see them. I think it's really important to keep engaging in those conversations. With that, I want to thank Longevity Small Cell Smashers, my good friend Dr. Shields, and of course my care team. And they mean the world to me. They're helping me every day take care of patients. This takes a village, and so really grateful to be able to do it. Thank you.
Okay, wonderful. Thank you, Dr. Singhi. Thank you for being here and going through the whirlwind of the last really 6 years that have really provided, I think, hope and real change for patients with small cell lung cancer. Again, please, as we're chatting, if you want to drop your questions in the chat, and will interrupt us as we're talking. So just to start us off, I think that, when we see with our smashers so many times, seeing somebody else's story where we have hope, right? We have those successes, we have those real life changes due to these FDA approvals. Can you give us an example of maybe a patient you've seen or a story that you could share with us of somebody who their life has been changed, maybe for the better, with these treatments?
Yeah, I think at MD Anderson, we have several clinical trials. Dr. Carl Gay is going to talk about some of those and really pushing and advocating for our patients to at least hear about clinical trials. I think sometimes we're rushing and always so nervous to get the patient started on a treatment that we don't unfortunately get to emphasize the importance of clinical trials and trying to move the needle forward in this space. And so I think the best cases of hope that I've seen personally in my clinic are patients that are on clinical trials, right? I have patients now, the median time for patients for chemotherapy and immunotherapy, the average time that patients live once they start that first drug for extensive stage disease is just over 12 months, right? And that's a really sobering number to share with patients. But I have multiple patients, and I'm so happy to say it. It makes me so happy to be able to participate in their care, seeing them now 2-3 years into their journey, right? And so that 12% number, I think, is going to continue to expand, that 5-year overall survival number. And it's because of progress, it's because of clinical trials.
Thank you, Dr. Singhi. And so I think, as we're thinking about these new therapies, maintenance strategies, right, we're seeing, patients on tarlatamab. I know personally I have patients who have been on it almost 2 years and have no evidence of cancer, had history of brain metastases, had evidence of extensive stage. And I think it's a real game changer. One thing I'd love to highlight here is with tarlatamab, there's this unique side effect that some of our patients who might be on treatment with tarlatamab may have experienced. About a third of patients on the study had it, called dysgeusia, or taste changes. Can you tell us what does that mean? What does that look like? And what are some ways that we can try to help patients through that side effect?
Yeah, so this is a really tough one. We have, I know, a paper coming out hopefully soon where we can offer some tips and tricks on how to manage it, but it's a real problem. Like I said, when the extensive stage small cell lung cancer comes back, it can come back sometimes very quickly with a vengeance, and that's where your teams, hopefully they've had plan B, C, and D ready, right? But go and activate the drug without offering all of the counseling, which I think is really important. Our goal is hopefully with tarlatamab that patients, if they have a response, they can have a long response, a sustained response. And just as important as having that response is making sure that patients feel healthy, right? That they feel supported, and that they have enough nutrition and strength to be able to continue on the drugs. And so that's where you're talking about the side effect can really impair it. So this change in taste, it's probably one of the hardest side effects to manage in oncology and cancer care. And there are some tips and tricks about, leaning in on certain foods, right? If they feel really good to you, using plastic silverware instead of like traditional silverware. There's small tips and tricks, but it's hard. The best one that I found is even before patients get started on tarlatamab, I refer them to our nutritionists and our dietitians. And I say, hey, listen, they're about to start a drug that is very likely to change their taste. And I really need help making sure that they shore up their nutrition and that they're ready to get started on this journey, because I want to keep them on the journey for a long time. And so my number one tip is refer them to a dietitian and a nutritionist and build a plan. So even if you've started on this drug and you haven't seen a dietitian, I would definitely ask your team for a referral.
I love that. And I think this is where our smashers, care partners, really can be empowered here, right? This is where you have full permission from us to say, remind your loved one to eat. Have you drank water? Did you drink enough water today? Have you gotten your protein in? what have you eaten today? Can I make you something? Can I make you some soup? Can I help in any way? Please, please, please feel fully empowered, right? We're giving you permission to say that we're going to make sure that you eat and stay healthy, happy, and full of good nutrients, right? We really, really want you to stay on therapy. And this can be a real side effect. And so if things don't taste the same, sometimes that changes how we view food. And please feel empowered as the care partner to nag them a little bit and just say, you got to eat okay. So I think that's a really, really important side effect that isn't talked about as much as we'd like, right? Anne, go ahead.
We have a few questions here. One question goes back, Dr. Singhi, to can you comment a little bit on the difference between tumor growth and tumor spread, and does that change your considerations for treatment?
Yeah, that's a really good question. So tumor growth, tumor spread, what it means is that we're getting worried that the treatment that a patient is on may not be controlling the cancer fully, right? And there's different patterns of tumor growth or tumor spread. Sometimes it can start to grow in multiple sites. And that's where we get really worried that we may have to change the drug that the patient is on sooner rather than later. If you think about it, if you have multiple sites, it's almost like you have to play catch up, right? And if you're going to keep them on the same treatment. So I often am thinking about multiple sites of growth, likely changing the drug treatment. If you have just an isolated site, one site, two sites that are growing, that may be an opportunity to say, hey, how much more juice can I squeeze out of the medicine that they're on, the drug that they're on, especially if patients are tolerating it well. And then call one of my friends in radiation oncology, like a radiation doctor, to go and see, okay, whatever that clone is, that disease that's growing, can you help me take care of it so I can keep the patient on a drug that they're tolerating well, controlling the rest of their disease quite well? How do you think about it?
Yeah, absolutely. I think that with small cell lung cancer, it has an ability, so different than non-small cell lung cancer. When we think about non-small cell lung cancer, it's usually mutation-based, like a broken gene that's turned on and driving the cancer, like EGFR, KRAS, these ALK fusions, et cetera, and those may pick up additional mutations, which are more so kind of permanent, right? So when we think about small cell, it's more so turning genes on and off instead of breaking them. And so they can kind of turn up the volume over here or turn up the volume over there, or right? And so it's a little easier for it to shift around depending on what it wants to do. And so that's where when we see things changing, we say maybe it's turning on a different knob over here that we need to pivot. But I fully agree when there's what we call oligoprogression, or less than really 5 spots, that we would like to try to target those with a local therapy like radiation and then keep going, because we know patients with oligoprogression are going to do really well. We really know that they're going to do well. And so if we can keep on the therapy as long as patients feel well, we really would like to do that. So again, it's a discussion with your care team to make sure that's the right option. Is it amenable to radiation? But we are thinking about, if it seems like the whole landscape has shifted, then we've got to pivot, right? We got to pivot to a different option because the small cell's thinking about pivoting too. So go ahead.
We have another question, and this is about tarlatamab. Can you discuss the actual treatment regimen? How long do you have to be in the hospital? Do you have to be in the hospital for every treatment? Or if you do well, can you get it as an outpatient? How does that work now?
Yeah, so there's actually several institutions as well too that are trying to change that and make it a little bit more convenient and patient-centered. So more to come on that. But as of right now, for most institutions, you have to be admitted into the hospital for your day 1 dose and your day 8 dose. If both of those go well, then you can receive all of your subsequent treatments in the clinic in the infusion center. Now that day 15, so after you finish that day 8, 1 week later, is a pretty long day because they're still watching you. This is the first time you're transitioning to the infusion clinic, and so it can be a really long day. And then as you make your way forward, the treatment ultimately becomes every 2 weeks. The observation period becomes shorter. So that's overall how I explain the schedule to patients.
And I think we have one more question here right now, and please, if you have questions, drop them in the chat. They're popping up for me. If you think that you have some suspicious symptoms and you really feel like you ought to be screened, how do you approach your physician how do you advocate for yourself to become screened?
Yeah, speak up loudly, speak up now. Bring that care partner with you, the one that always speaks up, bring them with you for sure and have them speak for you. I'm a big proponent of this. My focus at my institution is young onset lung cancer. So actually the majority of my patients that I'm seeing in my clinic now are under the age of 50. And I can't tell you the number of times where they said, hey, something just has not felt right with my body for quite some time. And I've been trying, I've been thinking about it. And they ultimately get a delayed diagnosis months later from when they first knew that something wasn't right. And so you are the experts of your body. If you feel like something is off, please speak up. And you should have hopefully a care physician or a care team that recognizes that listens to you, and that makes you feel like you're truly a partner in that relationship.
And I think this, not necessarily in this scenario, but this brings up a great point of second and third and fourth opinions, right? This is a village that is caring for you. And so we need to make sure that your voice is being heard, right? Our trials being considered, as there may be an option that's not at your institution or your center, but another center. And so I think, personally, I know Dr. Singhi feels very similarly or the same. We are not offended by someone getting a second opinion, right? Please, please, please. We want the best care for you or your loved one. And so if there might be someone that you need to see in another city or another state, speak up. We want to support you. Your care team wants you to do well and get the right treatments at the right timing. So,
There's also a question from someone about surgery in small cell. In non-small cell, our question is talking about when you do have spread or stage 4 disease, even then, sometimes we actually remove tumors in non-small cell. Do you think that this is ever going to be an option in small cell lung cancer?
So I'll define the space, and then I'm going to pass the mic back to Misty to answer the question definitively. So that's my cop-out. So what Ann is asking about is a concept called local consolidative therapy, or LCT. It's a very simple question, but it's deceptively simple. What it's asking is, for patients that have disease that's moved outside the chest, is stage 4 disease, if you start them on a drug therapy and they have a really good response to that drug therapy and there's maybe just a few spots left that are active on the scans, can we do something more than the drug therapy? Can we use surgery? Can we use radiation to clean up those spots that are still visible in the scans? Boost your response, right? Hopefully keep the patient on the drug treatment that they're on for longer, and hopefully that translates to them living longer. That's what LCT means. We're starting to do that a lot more in non-small cell lung cancer because our drug therapies, the response rates are exceptional. We're seeing 80, 90% response rates now. And I think hopefully one day small cell lung cancer will be there too, but let's see what Dr. Shields says.
Yeah, so I think surgery is an up-and-coming modality for small cell. So historically, it was felt that small cell was kind of a blood-based disease, and that although you maybe saw a small spot on a scan, because of how small cell it grows or how it's driven, we know that it has an ability to try to get out into the bloodstream quickly, even if the spot on the lung is teeny tiny. And so to be the best servants for our patients, surgery was almost a setback because it was time away from treatment, time off of treatment, and time to heal from your surgery to get back to the chemotherapy or IV therapies like immunotherapy that really were what helped fight this disease. But now we're seeing really in small cell lung cancer, even in patients who have stage 1, that we can go to surgery because it was found so early, and they get chemotherapy afterwards. And there's actually a trial being led by the Alliance by Dr. Jacob Sands and Jeff Yang, who's a surgeon at Mass General, to look at, can we add immunotherapy and really drill down the benefit we saw with limited stage from the Adriatic study. So I think surgery is going to be a modality or an option for patients. And I do love the idea that if there is a stubborn clone, if you will, that was there, maybe a spot on the adrenal that won't go away and everything else is shrinking, would surgery be a right option? And I think we're going to get there. I think this is where trials will be really important for patients who have spots that are just stubborn. I had a lovely patient who had chemoimmunotherapy, had a lymph node that had popped up while she was on lurbinectedin. Everything else melted away. And in her case, we did radiation, and she's on now over cycle 50 years later with complete response. And she just had that one stubborn lymph node that just needed a little additional kick with radiation. And so I think this is where we can use kind of 2 or 3 ways to target small cell to really drill down and make sure patients get the best response and live longer, healthier lives. So I think don't be scared to ask for other approaches and say, is there something we can add? Is there something more we can do to improve the outcomes? Again, it's a decision of making sure toxicities, is it right for you? Is it a safe option? But I think surgery might be in the future for small cell, especially in patients, let's say, who are on tarlatamab and had one spot that just wouldn't go away and everything else is gone, or lurbinectedin, everything's gone. We'll talk about ADCs or antibody drug conjugates more with Dr. Gay, but I think surgery is a real option here for patients, and it's going to be more and more.
Just a couple of more questions. I know we're getting close on time here. For those people in the community who do not have tarlatamab readily available to them, is there something that we can do as advocates, all of us as a community, to encourage community practices to include tarlatamab in their treatment regimen?
Yeah, I mean, I think constantly advocating and raising awareness about this fact that it is approved is the first step, right? But you also want to make sure that the place that you're at has all the support and the resources ready if there is a side effect, if there is a symptom that comes up, they know what to do. Because our goal is to make sure we can give the drug, but we give it safely, right? And so what we do a lot of times is patients we can see for their first dose or that second dose, they can go to an academic center, they can go to one of the university centers nearby, and then if things go well, then they can transition back home, right? And then they can safely get it close to home. And so we've done that quite frequently. I'm happy to help partner. We do a lot of these talks as well too, where we go out to community sites, we say, hey, listen, there's a new approval. I think there's so much doom and gloom with the diagnosis of small cell lung cancer. I can't tell you, where I go to different community practices, I do talks, and people still don't realize that there are still successful treatments after that first treatment of chemotherapy and immunotherapy. It's 2026. There's been multiple approvals, and people still don't realize that there is more hope after a patient's disease grows on chemotherapy and immunotherapy. So I think getting the word out, advocating for yourself, and then like Dr. Shields said, the second opinion can be life-changing for a lot of people.
And I think being, arming yourself, empowering your loved one to know these tools that are available, because you might be on plan A and you need to know B, C, D, right? And so knowing, okay, wait, there's this other drug, tarlatamab, and I know logistics are an issue, so how are we going to go around that, right? And this is where we want you to be empowered with knowledge so that you go back to your care team and we force that they get you get the best quality care possible wherever you are. And so, we want to help you and your loved ones get the care and hopefully breaking down a lot of these barriers. Again, that cytokine release syndrome really goes to almost 0 after day 15. And so, teams should not be scared of it. I have patients that are on cycles 3, 4, 5, 6. They're still worried about it. I'm like, it's not going to come. We're good. And so, I think it's really raising awareness and knowledge. And this is where you can go back and be empowered and say, no, the data shows this. This is the option I would like to try or like to be considered for if this is appropriate. And so we hope that you're armed and ready. You have your toolkit whenever you leave this conference to say, okay, here's my plan A, B, and C from here.
This is a really interesting question, and it's kind of a two-part. So what really is the difference between non-small cell and small cell? And is it possible that small cell has any sort of hereditary component?
Wow, these are really good questions, and this is probably more of the scientist types of questions. I'll just tell you clinically what the big differences are, kind of how it presents. So non-small cell lung cancer is the most common type of lung cancer, happens in about 80% of cases, and then small cell lung cancer is less common, right? But it's still a very significant disease, a very severe disease, and the biology of it is very different. Small cell lung cancer is growing very quickly, typically. It's growing by the day, by the week. Non-small cell lung cancer, the biology of it for most patients is growing slower. And so the presentation is different, the biology is different, a lot of unique differences. Misty, now tell us what happens in the lab.
So I think our timer, our cake is done up here. So yes, they are different diseases. Sometimes the maps, the kind of roads that the cancer can take to form may be very similar, but sometimes what it really comes down to is what cell did the cancer start from, and that's really where it gets back to a very kind of fundamental biology of the areas in the lung that the cancer had the genetic changes in. And they can have very similar genetic changes, but it's the cell of origin. And that's really still under a lot of debate. We always thought it was a neuroendocrine cell in the airway. Now we're thinking it might be kind of this kind of tough cell or basal cell that might be what's causing it. And then we know there's other kind of pulmonary kind of pneumocytes and things that the other non-small cells come from. But they may have very similar changes like P53 and RB. Those might be the same genetic changes, but in kind of the GPS of where it started is slightly different. And so that is really important for us to make sure that we tailor those treatments for your case, because the location might be different, the biology might be different, and that means the treatments are different for you. So, okay.
Okay. Great session.
Yeah.
Thank you so much, Dr. Singhi.
I guess I'll work from this mic, I guess. Okay. All right, well, one more time, let's give another big round of applause for Dr. Singhi. Thank you for your insightful knowledge.